Hello. Today I'm going to speak with you about bifurcation PCI. No conflicts of interest. Here are some learning objectives. By the end of the session, you'll be able to describe the anatomic and lesion characteristics that influence bifurcation PCI strategy selection, compare and contrast the major two-stent techniques such as TAP, Culotte, Crush family, and V-stent, including their advantages, limitations, and ideal use case scenarios. Explain how carina shift, plaque shift, and neocarina formation affect procedural planning and post-stent optimization. Perform technique-specific procedural steps with attention to key technical pearls such as pot, kissing, balloon inflation, and optimal rewiring strategies. Recognize situations where rapid protection of the side branch is essential and identify when crush techniques may be preferred to avoid prolonged ischemic time. And apply intravascular imaging to evaluate stent expansion, apposition, carina reconstruction, and troubleshoot flow limitation. We'll go over the classification. Then we'll talk about a bifurcation PCI algorithm. We'll go over step by step of the provisional techniques, then step by step of the two-stent techniques. Then we'll talk about side branch compromise and protection, side branch rewiring, and we'll briefly touch upon new technologies. Introduced in 2006, the Medina classification is the most widely used classification for bifurcation lesions due to its simplicity. It has three binary digits to denote the presence, 1, or absence, 0, of significant stenosis, meaning 50% or more diameter reduction, in three segments of bifurcation. These segments are the proximal main vessel, the distal main vessel, and the side branch, respectively. 7 total categories can be assigned, with 111 indicating significant stenosis in all three segments, or 100 indicating stenosis only in the proximal main vessel. Medina 111 and 110 are the most common at 36% and 27% of bifurcations, respectively. Medina 001 is the least common at 3.5%. Recently, the ABCD classification system was proposed to specifically describe left main bifurcation and trifurcation lesions to address several limitations of the Medina classification system. The Medina system cannot handle trifurcations and does not account for the size of the vessel. In the ABCD system, each artery is assigned a letter if it is significantly stenosed, defined as a more than 70% lumen reduction. Each of the four letters corresponds to the artery. Big A, small a refers to the left main artery. Big B or small b refers to the LAD artery. Big B, small c refers to the circumflex artery. Big D or small d refer to the ramus intermedius artery, if it is a trifurcation lesion. If the vessel diameter is at least 3.5 millimeters or higher, then an uppercase letter is used. If the vessel diameter is less than 3.5 millimeter, a lowercase letter is assigned. If the stenosis is not considered significant, then no letter will be assigned. This system actually allows for 256 different descriptions instead of the 7 vessel phenotypes of the Medina classification. Why do we care about vessel diameters? Because these diameters are not random. Finay's formula describes the relationship between the vessel diameters and coronary artery bifurcations. It states that the proximal main vessel diameter is 0.678 times the sum of the distal main vessel diameter and the side branch diameter. For an arterial trifurcation, the diameter of the proximal main vessel is 0.58 of the diameter of the distal main vessel and the diameter of the two side branches summed together. Why? Because the conservation of flow principle states that the total blood flow at the bifurcation point is conserved, meaning that the combined flow from the main vessel must equal the flow going into both the main and the side branch. The formula suggests that for the side branch to maintain an adequate flow, the diameters of the side branch to the main vessel need to be balanced so that the total flow through both vessels remains optimal. By Poiseuille's law, flow through a vessel is proportional to the fourth power of the radius or diameter of the vessel. Therefore, small changes in vessel diameter can lead to large changes in flow. When a side branch has a diameter similar to or greater than the main vessel, it is more likely to maintain adequate flow after stenting or balloon dilation. That's why we have to pay attention to the vessel diameters. Now that we've talked about the classification as the foundation for looking at bifurcation lesions, let's go over this bifurcation algorithm. This is an algorithm that we came up with, me and my colleagues, based on a review of various different algorithms, and I think this provides a simplified but effective approach. And this is also evidence-based. So let's see what we have here. The first decision point is whether the lesion is simple or complex. Using the definition 2 criteria, complex bifurcations are defined by the presence of severe side branch stenosis, at least 70% for the left main or at least 90% for non-left main, combined with extensive side branch disease, at least 10 millimeters in length, plus 2 additional high-risk factors: moderate to severe calcification, thrombus burden, multiple lesions, small main vessel reference diameter less than 2.5 millimeter, long main vessel lesions at least 25 millimeters, or challenging bifurcation angles less than 45 degrees or more than 70 degrees. For non-complex bifurcations, a provisional strategy is recommended. The rationale for main vessel stenting with conditional side branch intervention is rooted in multiple randomized trials showing similar outcomes to systematic two-stent strategies, but with shorter procedures, less contrast, and lower peri-procedural risk. If the side branch stenosis worsens beyond 75%, then you'll rewire through the distal strut using a non-polymer wire, perform post-dilation through the stent struts into the side branch, and perform kissing balloon inflation with optional proximal reoptimization technique or repot. If the side branch becomes severely compromised, meaning TIMI 3 less than 3 flow, at least 90% stenosis, or severe dissection, then you can proceed with a second stent. This approach maximizes the benefits of the single stent simplicity while providing clear criteria for escalation when anatomic or functional results are suboptimal. You can use T, tap, reverse culotte, or reverse crush. For complex bifurcations, an upfront two-stent strategy is recommended. Here, the choice of technique is tailored to the lesion morphology. T or tap stenting can be considered for a near perpendicular side branch angle, meaning 70 to 90 degrees. Culotte can be considered for vessels with similar reference diameters, with a diameter mismatch less than 1.5 millimeters. DK crush can be considered for complex left main bifurcations with a Medina 111 classification, or acute angles less than 70 degrees, or significant vessel size mismatch. V-stenting can be considered for Medina 011 lesions, although this latter technique is less commonly employed. Throughout both pathways, several overarching practice points should be kept in mind. Intravascular imaging with IVUS or OCT should be used liberally, particularly in left main or complex bifurcations, to guide sizing for stents, confirm adequate expansion, and assess for side branch osteal disease. Proximal optimization ensures that the main vessel stent conforms to its natural taper and facilitates easy, safe access to the side branch. Final kissing balloon inflation, while not always mandatory in simple provisional cases, is essential in all two-stent strategies to minimize strut distortion and optimize carina geometry. Now let's go through these provisional techniques. I'm going to show you step by step how to perform each technique through these original illustrations. What exactly is provisional stenting? The provisional stenting approach refers to a collection of techniques used in bifurcation intervention where only the main vessel is stented initially and the side branch is treated only if compromised. Provisional stenting is often preferred in situations where the side branch lesion is not severely diseased or is not expected to cause significant ischemia. The side branch ostium is not critically involved in the bifurcation lesion, and the main vessel is the primary concern. And the side branch has a favorable geometry, meaning the angle between the main vessel and side branch is not too sharp, reducing the likelihood of occluding the side branch when treating the main vessel. The side branch is left unstented unless there is evidence after the initial main vessel stent delivery that the side branch is significantly compromised and requires stenting. The lack of necessity in rewiring and kissing in a non-compromised side branch is supported by the results of the Cross, Nordic 3, and KISS trials. So, what are the steps? First, wire the main vessel and the side branch. Second, advance the stent into the main branch and deploy the stent. Third, advance a balloon in the proximal segment of the main vessel and perform POT, proximal optimization technique. Fourth, remove the balloon from the main vessel and perform an angiogram to evaluate flow in the side branch. If the side branch flow is intact with TIMI 3, then it is acceptable to end the procedure here and remove both wires. If the side branch flow is compromised, meaning TIMI flow is less than 3 or side branch stenosis is more than 70%, then proceed with rewiring the side branch through the distal struts of the main vessel stent. You can do this using the 2-wire technique or 3-wire technique for rewiring the side branch. In the 2-wire technique, you withdraw the main vessel wire back into the main vessel stent at the level of the side branch with the curved tip of the wire pointing in the direction of the side branch. You then enter the side branch to the stent struts. You withdraw the jailed side branch wire. Once the jailed side branch wire is withdrawn, advance it to the main branch using a rotational motion to keep the wire free and increase the chances of coursing within the stent lumen. There's also a 3-wire technique for rewiring the side branch. While the main branch wire remains in place, bring a third wire into the main vessel stent at the level of the side branch with the curved tip of the wire pointing in the direction of the side branch. Enter the side branch through stent struts. Remove the jailed wire from the side branch out of the body. Note that the main vessel wire remains in place throughout the whole time in the main vessel. Now that you've rewired the side branch, you can proceed and advance the balloon in the main vessel and the balloon in the side branch vessel. In step 7, you'll perform kissing balloon inflation with the side branch stent balloon and the main branch balloon. You can then remove both balloons. This is an optional step. You can perform POT or proximal optimization technique again after the kissing balloon inflation to prevent oval distortion of the proximal main branch by the kissing balloon inflation. Lastly, you'll perform an angiogram to evaluate the flow in the side branch. If the side branch flow is intact, meaning TIMI 3, it is acceptable to end the procedure here and remove both wires. If the side branch flow is compromised, meaning TIMI flow less than 3 or side branch stenosis exceeding 90%, then stenting of the side branch may be necessary. You will then proceed with a stent after provisional approach, such as TAP. How do you perform TAP? TAP is the T and protrusion technique. This technique picks up from the last step of the provisional stenting technique, which is the last step of the last slide you saw. After you have rewired the side branch and dilated through the main vessel stent struts with a small compliant balloon at high pressure. So you'll then advance a stent into the side branch across the side branch ostium, but do not deploy it yet. You'll advance a balloon sized 1-to-1 to the main vessel stent, but shorter than a main vessel stent, and position the center of the balloon at the carina of the bifurcation. Make sure that this balloon does not protrude outside of the original stent. The reason you cannot deploy your side branch stent before first advancing a balloon in the position of the main vessel is that a deployed stent in the side branch may have protruding stent struts that prohibit the advancement of the main branch balloon. The main vessel balloon should be positioned and waiting, and the undeployed side branch stent should be positioned and waiting. Fourth, you'll pull back the side branch stent such that it protrudes minimally 1 to 2 millimeters into the main vessel. Deploy the side branch stent. You'll then perform an angiogram to verify that there is no distal dissection that would require the delivery of a second stent into the side branch. Do not remove the wire from the side branch because you have no plans for crushing and rewiring the side branch stent. Instead, you'll perform kissing balloon inflation, so at no point does your side branch become fenced off in the tap technique. The next step is to take the stent balloon of the already deployed side branch stent and slightly withdraw it further into the proximal main vessel, such that part of the balloon protrudes proximally into the side branch stent. Align the proximal tip of the side branch balloon with the proximal tip of the main vessel balloon. Then perform kissing balloon inflation with the side branch stent balloon and the main branch balloon. Deflate both balloons, but make sure to deflate the main branch balloon first before deflating the side branch balloon. If you inadvertently deflate the side branch balloon before deflating the main branch balloon, you will crush the proximal stent struts of the side branch into side branch ostium, which would then force you to convert to a reverse crush technique and have to rewire the fenced off side branch. Remove both balloons, paying attention so as to not lose wire position. And optionally, you can perform a post dilation of the proximal main branch for proximal optimization. Note that the distal marker of the balloon used for pot should be positioned just proximal to the neocarina, because now, remember, your side branch stent has created an artificial carina that is 1 to 2 millimeters more proximal than the original carina of the bifurcation. Beware that if you mistakenly advance the pot balloon beyond the neocarina, you will crush the protruding proximal struts of the side branch stent. At that point, you may have to consider either converting to a reverse crush technique or rewire the fenced off side branch to reopen the partially crushed side branch stent by performing another kissing balloon inflation, since there is still a wire in the side branch to the side branch stent lumen. For this reason, final pot is not a required step in the tap technique. To reduce the risk of pot ballooning beyond the neocarina, stent boost or stent vis mode should be used to visualize the position of the pot balloon in tap. Then, you remove the balloon used for pot and perform an angiogram for final assessment. Some practice points I want you to know about tap. The advantage of tap is that it does not require rewiring of the side branch, which reverse crush requires. The drawback of tap is that it creates a neocarina more proximal than the original carina, which may impede the ability to advance equipment into the main vessel. The position of the neocarina is determined by the angle of the side branch takeoff and the site of strut crossing. When a side branch has a T-shaped takeoff, meaning 90 degrees, only small or absent stent protrusion from the side branch is needed to successfully cover the side branch ostium. When a side branch has a Y-shaped takeoff, meaning an acute angle, generally less than 60 degrees, a longer oval-shaped protrusion of the side branch stent may be needed to adequately cover the side branch ostium, creating a neocarina. Some tips for a successful tap with minimal or no protrusion, particularly when you have narrow angles less than 60 degrees. Be sure to perform proper main branch pot, which lifts some of the main branch stent struts into the ostium of the side branch. Rewire the side branch through distal stent struts. This allows the side branch balloon dilation to lift the main branch stent and scaffold the upper arm of the side branch, the one most difficult to cover. I'll show you a picture of this shortly. Use stent boost or stent vis technology to minimize protrusion while avoiding the ostial miss. consider using a balloon-assisted tap technique, meaning inflate a balloon inside the main branch while positioning the side branch stents. Then pull the side branch stent until it meets resistance from the inflated main branch balloon. Then deflate that balloon and deploy the side branch stents. What do we mean about distal crossing versus proximal crossing? When rewiring through the main branch stent struts to re-enter the side branch in provisional side branch ballooning, in the tap technique, TN protrusion, and the Culotte technique, it is preferable to cross through a distal strut as close as possible to the carina rather than through a proximal strut, as illustrated here in the second row. We'll start with the top row, distal crossing before tap, which is preferable. You'll start by rewiring through the main vessel stent struts into the side branch through a distal cell. The side branch balloon dilation consequently lifts the main branch stent and allows it to scaffold the upper arm of the side branch so that subsequent delivery and deployment of the side branch stent in the tap technique results in a final result with minimal protrusion of the side branch stent to the main vessel. In the bottom row, you'll see the consequence of proximal crossing before tap, which is less preferable. Rewiring through the main vessel struts done through a proximal cell leads to subsequent balloon dilation that deforms the main vessel stent at an angle that opens perpendicularly into the side branch wall rather than into the side branch lumen, as you see here, such that subsequent delivery and deployment of the side branch stent in this tap technique results in a final result with a significant undesired protrusion of the side branch stent in the main vessel. In contrast, crossing through a proximal strut or mid strut is preferable in the crush family of techniques. So what I'm showing you here, this concept applies to tap technique and Culotte technique. The T technique was the predecessor of the T and protrusion technique. The same steps are followed, but whether the result is T or tap technique determines on how perfect the tap technique was applied and how much the side branch stent ends up protruding into the main vessel. If the main vessel struts are rewired through a distal strut, particularly with a favorable bifurcation angle, the result is a side branch stent deployed with no protrusion, which is called a T. If the side branch stent is deployed more proximally with a 1 to 2 millimeter protrusion in the main branch, as shown in the previous series of steps, then it is a tap instead of a T. T and protrusion for tap. I want to show you a real-world example of provisional technique. Here we have a diagnostic angiogram that revealed a severe 95% stenosis in the proximal LAD at a Medina 0-1-0 bifurcation with the first diagonal. And according to our algorithm for bifurcation PCI, this true bifurcation mean definition criteria for complex bifurcation. I'll play it for you again. You can see it actually does not meet definition criteria for complex bifurcation. So in that situation, it's reasonable to go through the left side of our algorithm and consider provisional stenting of the main vessel, which is what was done. Here you can see predilation of the main vessel, positioning of a long stent in the main vessel, and deployment of that stent in that main vessel. Here is the initial result. So you can see the stent is nicely placed here. Post-dilation was done. Here is the positioning of the post-dilation balloon, and here is the post-dilation of the main vessel stent. Then kissing balloon inflation was performed. Here's the positioning of the balloons in the main vessel and side branch for kissing, and kissing balloon inflation occurred here. Unfortunately, it turns out that the ostium of the side branch ended up being pinched. So in this situation, IVUS was used to reveal what was going on. And it revealed that there was near 90% ostial obstruction in that side branch, even more so than was shown by angiogram. This is the IVUS catheter you can see over here. So in this situation, we proceeded to position a stent in the side branch with additional balloon ready in the main vessel. So this one's the stent, this one is the balloon in the main vessel. Then here you see deployment of the stent in the side branch. And then this is finished with a kissing balloon inflation. Here's the final result. So you can see this is a very, very nice result where you have delivery of two stents. It was a 3.0 by 38 synergy to the LAD and a 3.0 by 16 synergy to diagonal one in a provisional manner that led to subsequent two stent technique. All right, now let's move on to the right side of this chart. There are several two stent intention to treat techniques. Classic crush, mini crush, nano crush, and DK crush can be thought of as a collection of variations on the same technique. Inverted culotte and reverse culotte can be thought of as variations on the same technique. V-stent and simultaneous kissing stent can be thought of variations on the same technique. We will start with the crush family of techniques. The initial description of crush or classic crush was quite basic. First, you wire the main vessel and side branch. Then, you advance a balloon in the main vessel and perform predilation of the main vessel. You then advance a balloon in the side branch and perform predilation of the side branch. You advance both the side branch stent into the side branch and the main vessel stent in the main vessel. You'll pull back the side branch stent such that there is a 4 to 5 millimeter protrusion proximally into the main vessel. You'll deploy the side branch stent first, perform an angiogram to verify that there is no distal dissection that will require delivery of a second stent to the side branch. Now that you have stented the side branch, remove the side branch stent delivery system. You'll then deploy the main vessel stent. This crushes that 4 to 5 millimeter proximal segment of the side branch stent that was protruding into the main vessel. You'll remove the main branch wire and remove the side branch wire and perform an angiogram for final assessment. In this original description of the classic crush technique from 2003, which is a long time ago, this was considered the end of the procedure. Subsequent versions of crush introduced the concept of rewiring the side branch to the gel struts and performing kissing balloon inflation. Subsequent versions also introduced the importance of post-dilation of this proximal segment of the main branch stents, known as POT, proximal optimization technique. In modern day parlance, with the incorporation of kissing balloon inflation and POT, which I'll show you in subsequent illustrations, classic crush, mini crush, and nano crush are considered to be the same technique, varying only by the degree of the side branch stent protrusion. 4 to 5 millimeters for classic crush, 2 to 3 millimeters for mini crush, and 0.5 to 1 millimeters for nano crush. How do you perform mini crush or nano crush? It differs there by the size of the sheath and the size of the guide catheters that you use. Recognizing that a 4 to 5 millimeter protrusion of the side branch stent was not necessary and led to a large volume of crushed stent and thus greater stent deformity, the mini crush technique reduced the amount of protrusion from 4 to 5 millimeters to 2 to 3 millimeters. As I said, this technique depends on whether 7 French or 6 French is used. The 7 French technique is preferred over the 6 French technique as the 7 French technique provides more stability and allows for the advancement of two stents delivery systems together. Whereas in the 6 French technique, which I'll show you in the next screen, you're going to have to deliver the two stent delivery systems in a step-by-step manner instead of parallel. So let's go through the steps. You start, as always, by wiring the main vessel and the side branch. You'll advance a balloon in the main vessel and perform predilation of the main vessel. You'll advance a balloon in the side branch and perform predilation of the side branch. You'll advance both the side branch stent into the side branch and the main vessel stent in the main vessel, and then pull back the side branch stent such as there is a 2 to 3 millimeter protrusion proximally into the main vessel. Deploy the side branch stent first and perform an angiogram to verify that there is no distal dissection that will require the delivery of a second stent into the side branch. Now that you have stented the side branch, remove the side branch stent delivery system and deploy that main vessel stent. This crushes that 1 to 2 millimeter proximal segment of the side branch stent that was protruding into the main vessel. Rewire the side branch through the struts of the main vessel stent and the crushed proximal struts of the side branch stent. Rewire through non-distal struts or proximal or mid struts, unlike in the provisional strategy and Culotte technique or TAP, where rewiring was performed through distal struts. Here's your rewiring. And once you've rewired, perform post-dilation of the proximal main branch for proximal optimization using a balloon-sized 1-to-1 to the proximal main vessel. Advance a small profile compliant balloon and perform high-pressure dilation through the struts of the main vessel stent into the side branch. As such. Now that you have an opening into the side branch again, advance a non-compliant balloon into the side branch and a non-compliant balloon into the main vessel. Line up the proximal dots and perform kissing balloon inflation. Remember, when you go up on the kissing balloon inflation, you have to go up together. And so it helps for you and the other operator to count, 2, 4, 6, 8, 10, 12, such that you're doing a controlled inflation at the same time. An alternative technique is to use a Y-shaped connector and use a single indeflator to go up on both balloons at the same time. Finally, perform post-dilation once again of the proximal main branch for proximal optimization using a balloon-sized 1-to-1 to the proximal main vessel. Then perform an angiogram for a final assessment. How about performing mini crush using the 6 French system? In a 6 French system, it is not possible to advance 2 stent delivery systems together. One stent delivery system has to be removed before the other stent delivery system can be advanced. Therefore, mini crush performed using a 6 French system has to be modified as follows. Start as always by wiring the main vessel and the side branch. Advance a balloon in the main vessel and perform pre-dilation of the main vessel. Advance a balloon in the side branch and perform pre-dilation of the side branch. Advance the side branch stent into the side branch and the main vessel balloon into the main vessel. Pull back the side branch stent such that there is a 2 to 3 millimeter protrusion proximally into the main vessel. Note that in the 7 French technique, you would be advancing stents into both the side branch and the main vessel, whereas in the 6 French technique, you can't put 2 stents parallel through that 6 French, so you're advancing a stent to the side branch and a balloon into the main vessel. Deploy the side branch stent first and perform an angiogram to verify that there's no distal dissection that will require the delivery of a second stent in the side branch. And now that you have stented the side branch, remove the side branch stent delivery system and side branch wire. Throughout this time, the main vessel balloon is patiently waiting in place. Now, you inflate the already positioned main vessel balloon. This crushes the 1 to 2 millimeter proximal segment of the side branch stent that was protruding into the main vessel. Remove the main vessel balloon and insert the main vessel stent. Now you can finally deploy the main vessel stent. Note that the deployment of the main vessel stent is not responsible for crushing the 1 to 2 millimeter proximal segment of the side branch stent, as in the 7 French technique, because in the 6 French technique, this proximal 1 to 2 millimeters was already crushed by the main vessel balloon in this step. You'll rewire the side branch through the non-distal struts of the main vessel stent and the crushed proximal struts of the side branch stent. Note that in the 7 French technique, you'll be rewiring through the crushed proximal struts of the side branch stent immediately after crushing it, but in this 6 French technique, you cannot rewire it immediately because you have to wait for the main vessel stent to be inserted and deployed before you rewire through the side branch. Now that you have deployed both stents and rewired the side branch, perform post-dilation for the proximal main branch for proximal optimization using a balloon size 1-to-1 to the proximal main vessel. Advance a small profile compliant balloon and perform high pressure dilation through the struts of the main vessel stent into the side branch, and then remove this balloon. Now that you have an opening into the side branch again, advance a non-compliant balloon into the side branch and a non-compliant balloon into the main vessel and line up dot to dot proximally and perform kissing balloon inflation. Finally, perform post-dilation once again of the proximal branch for proximal optimization using a balloon sized 1:1 to the proximal main vessel. Perform an angiogram for final assessment. So I hope this gives you a nice visual overview of the 6 French versus 7 French techniques for mini crush and nano crush. Several practice points I want you to know about crush. There's one major scenario where the crush family of techniques is advantageous compared to culotte and tap. The case of critical disease, more than 90% in both the distal main vessel and the side branch, where the first stent deployment in one distal branch may result in occlusion of the other distal branch due to plaque shift. In the crush technique, constant balloon access is maintained to the other distal branch, whereas in culotte and tap, there's only jailed wire access to that other distal branch, and rewiring it is needed before being able to balloon it. Prolonged ischemic time of the occluded side branch may result from difficulty rewiring. Thus, crush techniques are preferred in the case of critical disease in both distal branches. I want to show you an example of the crush technique being performed in real life. In this angiogram that we did, we found severe 95% stenosis in the proximal LAD with severe 90% stenosis in the first diagonal at a Medina 1-1-1 bifurcation with moderate calcification in the side branch, and giving you 2 different views of this very severe bifurcation over here. So we performed predilation of the side branch, and then we did predilation of the other branch, and then we positioned a stent in the side branch. Here, we're deploying the stent at the side branch. Then we performed position a stent in the main vessel and then deployed that stent in the main vessel over here. So please note that this is a caudal view. Okay, so this is going to be your LAD and this is your branch over here. Diagonal branch. Okay. Now, here we perform pot in the main vessel stent, although this, this actually violates what the rule I told you earlier. If we were following this by the book, we have chosen a pot balloon that did not cross the carina, so a shorter pot balloon. Then we dilate it through the recross side branch and then perform kissing balloon inflation. You can see here, this is our 2 kissing balloon inflations side by side at the same time. Then we perform repot in the main vessel stents. So this is our final result after performing crush. So this was an IVUS-guided 6 French mini crush PCI with PCI predilation, shockwave lithotripsy to the first diagonal. I skipped that. I didn't show you the shockwave step. And delivery of a 2.5/24 synergy drug-eluting stent to the first diagonal over here, and a 4.0/20 millimeter synergy stent to the proximal LAD. And we have nice TIMI 3 flow as the final result here. Now, let's talk about the double kissing technique, or DK crush. An additional kissing balloon inflation was added right after deployment of the side branch stent in order to clear the crust struts of the side branch stent away from the side branch ostium in order to increase the likelihood of successful recross after the subsequent main vessel stenting. This technique is thus called double kissing, or DK, because kissing balloon inflation happens twice. First, after the deployment of the side branch stent, but before the insertion of the main vessel stent. And second, after deployment of both stents and rewiring and strut dilation of the side branch, but prior to the final pot. In contrast, single kiss techniques refer to classic crush, mini crush, and nano crush. So what do we do here in DK crush? As always, start by wiring the main vessel and side branch. Advance a balloon in the main vessel and perform predilation of the main vessel. Advance a balloon in the side branch and perform predilation of the side branch. Advance both the side branch stent to the side branch and the main vessel balloon in the main vessel. Pull back the side branch stent such that there is around a 2 mm protrusion proximally into the main vessel. Deploy the side branch stent first. Perform an angiogram to verify that there's no distal dissection that will require delivery of a second stent into the side branch. Remove the stent delivery system from the side branch. Inflate the balloon that was patiently sitting waiting in the main vessel, thereby crushing the proximal edge of the freshly deployed side branch stents, and then remove the main vessel balloon. Rewire the side branch through the struts of the main vessel stent and the crushed proximal struts of the side branch stent. Then advance a small profile compliant balloon through the struts of the side branch stent and advance a balloon into the main vessel. Perform simultaneous kissing balloon inflation and remove both balloons. Now, you'll advance a stent into the main vessel and deploy it. As such, you'll rewire the side branch to the non-distal struts of the main vessel stent. In DK crush, the attempt to rewire the side branch only has a cross through one layer of stent, the main vessel stent, because the proximal crush struts of the side branch stent were already opened up in the first round of kissing balloon inflation. In contrast, in classic crush and mini crush, the attempt to rewire the side branch requires the wire to cross both the main vessel stent struts and the crushed side branch stent struts. After rewiring, you'll perform post-dilation of the proximal main branch for proximal optimization using a balloon size 1:1 to the proximal main vessel. You'll then use a small profile compliant balloon and perform high pressure dilation through the struts of the main vessel into the side branch. And then you'll advance a non-compliant balloon into the side branch and a non-compliant balloon into the main vessel, line up the proximal dots, and perform kissing balloon inflation. Finally, perform post-dilation once again of the proximal main branch for proximal optimization using a balloon size 1:1 to the proximal main vessel. That's not shown here. And then you'll perform a angiogram for final assessment. Moving on from the crush family of techniques, it's important to know about the Culotte technique. Culotte techniques are appropriate for Y-shaped angulated bifurcations that are approximately the same size distally. And so you'll notice in this illustration, instead of showing the main vessel and side branch in this configuration, I've shown it kind of as like a Y shape with approximately equal legs. As always, we'll start with wiring the main vessel and the side branch. You'll advance a balloon in the main vessel and perform predilation of the main vessel. Advance a balloon in the side branch and perform predilation of side branch. Then advance the side branch stent into the side branch. You'll position that side branch stent such that the proximal portion covers the entirety of the disease segment of the proximal main branch, and the distal portion covers the entirety of the disease segment in the side branch. So you may end up using a long stent in order to accomplish this. Note that this is in contrast to mini crush, where you only pull back just enough before the carina, such as there's a 2 to 3 millimeter protrusion proximally into the main vessel. In Culotte, you cover the entirety of the proximal main vessel in addition to distal. Then you deploy the side branch stent. This assumes that the side branch is more angulated. If the main branch is more angulated than the side branch, then you should treat the main branch as a side branch throughout the entire procedure and perform stenting of that first. Perform an angiogram to verify that there's no distal dissection over here that will require delivery of a second stent in the side branch. Remove the side branch stent delivery system, but not the side branch wire. Perform proximal optimization of the this segment over here using a balloon size 1:1 to the proximal main vessel. Note that this does further jail the main vessel wire. So this is your first pot. You rewire the distal main vessel using a new wire through the struts of the freshly placed stent in the side branch, extending back in the proximal main vessel. You rewire the stent struts distally, similarly to provisional stenting. Once you have rewired the distal main vessel, you can remove the gel main vessel wire. Use a small profile compliant balloon and perform high pressure dilation through the struts of the side branch, proximal main vessel stent into the distal main vessel. Optionally, you can perform kissing balloon inflation, in which case the culotte will become DK culotte or double kissing culotte. This is not depicted here since it's optional. The kissing balloon inflation may facilitate rewiring a further step. Then you'll insert through this hole the main vessel stent, such that part of it protrudes into the distal main vessel past the carina, and a significant portion of it overlaps with the first stent in the proximal main vessel. You'll then deploy that main vessel stent and remove the delivery system from the main branch, but not the main branch wire. Perform post-dilation of the proximal main branch for proximal optimization using a balloon size 1:1 to the proximal main vessel. This further jails the side branch wire. Note that this is the second pot. Rewire the side branch through the struts of the main vessel stent. Once you have rewired the side branch, you can remove the jailed side branch wire. Advance a non-compliant balloon into the side branch and non-compliant balloon into the main vessel. Line up the proximal dots dot to dot and perform kissing balloon inflation. Inflate only the side branch balloon at high pressure, then inflate only the main branch balloon at high pressure. In Culotte, it does not hugely matter which balloon inflation happens first, so it is okay to perform main branch balloon inflation before side branch balloon inflation, in contrast to what I said in an earlier slide. Note that you have now that you have individually inflated each balloon, simultaneously inflate both the main branch balloon and the side branch balloon at 12 to 14 atmospheres, and deflate both balloons at the same time. Again, this can be done with two inflators, with both operators calling out the numbers, going up simultaneously and coming down simultaneously, or you can do it with a single inflator with a Y connector. Deflate both balloons and then remove both balloons. Finally, an optional step, you can perform post-dilation once again of the proximal main branch using a balloon size 1:1 to the proximal main vessel. In Culotte, this final and third pot is optional since you have already performed pot twice earlier in the procedure, over here and over here. Therefore, it's not illustrated in this diagram. Of course, you'll perform a final angiogram for assessment. There's several important practice points I want you to know about Culotte. Culotte should not be performed if there is a major vessel mismatch between the main branch and the side branch exceeding 1.5 millimeters. The major drawback of the Culotte technique is that it leads to an excess of metal covering the proximal end, as there are two full layers of stent in the proximal part of the main vessel. The advantage of Culotte is that it gives the fullest coverage of the carina. With regard to which branch to stent into first, since there may be ambiguity about which branch should be designated as a side branch, the first stent is traditionally placed from the proximal main branch into the most angulated side branch or the most critical side branch. In that case, the distal main branch may be referred to as the assigned side branch. This is referred to as inverted culotte. Alternatively, if the first stent is placed from the proximal main branch into the distal main branch, then it is referred to as reverse culotte. So that's the difference between inverted culotte and reverse culotte. I want to show you a real world example of a culotte procedure that we performed. So here you can see I've annotated you have a non-calcified severe 70% disease of the mid LAD, which we'll need to modify. And you'll have this heavily calcified severe 70, 80, 70% disease at a Medina 111 bifurcation of the distal left main, ostial LAD, and ostial circumflex. And I'm showing you a different caudal view here, where you see this Medina 111 bifurcation with heavy calcification. There are many steps that were performed prior to starting the culotte proper, including serial predilation of the left main into LAD, cutting balloon angioplasty and rotational atherectomy, and delivery of one stent into that other mid-LAD lesion. So I'm just showing you briefly here. This one is the rotational atherectomy, and this one is the delivery of that stent. Now that we've adequately prepared it, we can proceed with our bifurcation PCI. Here's the predilation of the main vessel, and here's the predilation of the side branch, and here is the positioning of the stent in the side branch. Here is the delivery of the stent in the side branch extending back into the proximal main vessel, and here is our pot after the initial stent. Here is where we were trying to position the stent in the main vessel while in caudal view. And then we changed to cranial view and positioned that stent in that main vessel. And you can see how it's helpful to get orthogonal views or different views. Here we're deploying the stent in the main vessel. And we performed the second pot after deployment of the second stent over here. Here is our final kissing balloon inflation. Okay. And this is what we get as our final result. So let me annotate this for you. So here we've done an IVUS guided PCI with rotational atherectomy, cutting balloon angioplasty, serial predilation, and delivery of a 3.5 by 20 megatron stent to the left main ostial circumflex, and a over here, and a 3.5 by 28 megatron stent to the left main ostial LED using the Culotte technique. And our stenosis are reduced to 0%. Here is another view. This is a cranial view. So you can see that over here. And then this was that other stent that we did to the mid LED. I want to talk to you about V-stenting and simultaneous kissing stent. V-stenting, which I'm going to show you in the next slide, is the positioning of two stents for distal disease. The drawback of V-stenting is the formation of a neocarina from the new stents that can hinder the ability to advance equipment in the future. The advantage of V-stenting is its simplicity in that there's no rewiring needed and no kissing balloon inflation needed. We will never lose access to either of the branches. It is simple, but it is not elegant. Because it requires simultaneous delivery of both stents, V-stenting can only be performed in a 7 French system. V-stenting should be used, I shouldn't say should, V-stenting is permitted to be used in Medina 011 bifurcations, i.e. bifurcations with disease in the distal main branch and side branch, with no significant disease in the proximal main vessel. And here are the steps. You'll wire the main vessel and side branch. Note that in V-stenting, you're treating the side branch and distal main vessel symmetrically such that you can place two stents in a V shape. Therefore, from here onward, you can refer to the side branch and distal main vessel both as distal branches. You'll advance a balloon into the main branch, taking care to reduce balloon involvement of the healthy proximal segment, since if this is truly a 011, then you should not have to do anything to the proximal segment, and perform predilation. You'll then advance a balloon in the side branch, taking care to reduce balloon involvement of a healthy proximal segment, and perform predilation. Advance one stent each into each distal branch. There should not be need to significantly overlap in the proximal vessel because this technique is not supposed to be used if you have significant proximal vessel disease. Adjust the position of both stents such as they are protruding only 1 to 2 millimeters in the proximal vessel, and simultaneously inflate both stents. Take care to deflate both stents simultaneously as well. Then remove both stent delivery systems, and you can perform an angiogram for final assessment. The simultaneous kissing stent technique is the exact same thing as V-stenting, except the protrusion into the proximal vessel is significantly more than 1 to 2 millimeters, creating a significant double barrel segment of stent in the proximal vessel. And I'm exaggerating this over here, both in this spot and this spot, because I'm trying to show you the consequences of this double barrel. The biggest disadvantage is this long neocarina, which will make subsequent equipment delivery unnecessarily challenging. Simultaneous kissing stents should only be used in an emergency or for bailout when there are no other two stent techniques that can be performed in time. Simultaneous kissing stent should not be confused with simultaneous kissing balloon inflation, which is part of almost every technique we've talked about. The MADS classification, which was proposed in 2008 by the European Bifurcation Club, provides an approach for defining and grouping coronary artery bifurcation stenting techniques based on the final position of the stents and the implantation order. On the top row, on the top axis, you can see the classifications: main proximal first, main across side first, double first, side branch first. I'll talk through all of these with you. And in the vertical axis, we go through the first stent, after balloon, second stent, and the third stent if necessary. Not all of the cases will have this third stent. Unlike the widely used Medina classification, which is focused on categorization of the lesions of the pre-existing disease, MADS is the classification on procedural stent deployment strategies. So main, or M, refers to techniques that begin with the proximal main segment, stenting the main vessel prior to treating a side branch. So, such as the skirt technique, which I did not actually illustrate for you in this lecture. A, across, refers to techniques that begin with stent in the main vessel across the side. So this could be TAP, it could be Culotte, internal crush, or elective T-stenting. D, which is distal or double, refers to techniques that involve double stent implantation simultaneously or not. So that's the V-stenting and simultaneous kissing stent that we talked about. S, or side branch first, refers to the techniques that begin with stent in the side branch with protrusion or without protrusion. This is usually employed when preserving side branch access is critical due to high-risk occlusions. Following the first stents, additional stents may be placed during using different techniques. So crush, mini crush are examples of this side branch first. Now that we have a very, very thorough understanding of the step-by-step for each of the different techniques, I want to talk about some considerations for side branch compromise and protection. In this illustration, you'll see I wanted to show you that there are several important anatomic and procedural risk factors that predict when the side branch may be at risk of compromise. Plaque on the same side of the side branch. This refers to atherosclerotic plaque located on the side of the main vessel that is directly opening to the origin of the side branch, in contrast to atherosclerotic plaque located on the opposite side of the opening of the side branch. During main vessel stent deployment, plaque on the same side is more likely to shift in the side branch ostium, increasing the risk of occlusion. Unfavorable bifurcation angle more than 70 degrees. A wide angle greater than 70 degrees is more likely to result in plaque shift and have hemodynamic compromise. It also alters the flow dynamics, whereas a more gradual angle, 0 to 70 degrees, it generally allows for easier access into the side branch and reduces the risk of compromise. Spiky carina. A sharply pointed carina, which is the central ridge between the main vessel and side branch, identified in imaging, such as OCT or IVUS, indicates unstable geometry. Main vessel stenting can displace this structure into the side branch, contributing to compromise or occlusion. A small side branch size, so side branch with a diameter less than 2.5 centimeters, are more vulnerable to compromise. A large main vessel relative to side branch, defining as a high ratio of main vessel diameter side branch ratio of at least 2, suggests a significant size mismatch. During the main vessel stent expansion, this can cause disproportionate plaque shift into the smaller side branch, which has less margin for handling plaque shift without resulting in a obstruction compared to something that's more than 2.5 centimeters side branch diameter. Also pay attention to the percent diameter stenosis of the bifurcation core. The bifurcation core is the central area encompassing the main vessel just before and after the side branch takeoff. A high-grade stenosis of more than 70% suggests that the large plaque burden may easily shift or snowplow into the side branch during stenting. A severe percent diameter stenosis at the side branch of 90% for the non-left main and more than 70% for left main lesions High-grade stenosis of the ostium or shaft before intervention increases the chance of total occlusion when the additional plaque is displaced during main vessel stenting. Then also look at the Timmy flow. If the Timmy flow is less than 3 in the side branch at baseline, that indicates impaired perfusion, often due to existing lesion severity and microvascular dysfunction. Lower flow suggests the side branch is more vulnerable and less likely to tolerate any additional obstruction compared to Timmy 3 flow. And then ostial lesion location of the side branch. If the lesion is located proximally or ostially on the side branch, closer to the bifurcation, the side branch is more likely to be compromised. You can predict the risk of side branch occlusion using the resolve score. In addition to the widely used jailed wire technique, which passively preserves access to the side branch during main vessel stenting, several active side branch protection techniques have been developed to further mitigate the risk of side branch occlusion. The jailed uninflated balloon technique, first described by Berzota et al., involves advancing a small uninflated balloon into the side branch, which is then jailed during the main vessel stent deployment. This uninflated balloon helps reduce mechanical plaque shift into the side branch, in addition to preserving access to the side branch. If the side branch becomes occluded, the jailed balloon can be inflated to restore flow. If the side branch does not become occluded, the side branch balloon can be withdrawn, followed by pot. In the jailed semi-inflated balloon technique, the side branch balloon is inflated at low pressure, 3 to 4 atmospheres, while the main vessel stent is deployed at nominal pressure. The proximal segment of the side branch balloon is compressed against the vessel wall as the main vessel stent inflates, while the distal segment of the side branch balloon becomes overinflated and completely occupies the side branch ostium, thus preventing plaque shift. If the side branch balloon does not become occluded, the side branch balloon can be withdrawn, followed by pot. Please note that in the gelled uninflated balloon technique and the gelled semi-inflated balloon technique, the proximal marker of the side branch balloon is positioned such that it is proximal to the proximal edge of the main branch stent, which is not the case in the subsequent techniques. And the modified gel balloon technique, the side branch balloon is placed in the side branch with a 1 millimeter protrusion into the main branch, whereas in the gel balloon stent kissing technique and the gel double kissing balloon technique, the side branch balloon is placed proximally in the main branch, although care is taken to ensure it does not protrude proximally to the main branch stent edge. In the jailed balloon stent kissing technique, the side branch balloon is inflated at low pressure, 6 to 8 atmospheres, while the main vessel stent is deployed at nominal pressure. After the jailed side branch balloon is deflated and removed, with the wire left in the side branch, the main vessel stent balloon is fully inflated to correct any stent deformation that was present during the initial inflation. In the jailed double kissing balloon technique outside the stent technique, the side branch balloon is used for two inflations. During the first kissing inflation, the side branch balloon is inflated at 6 to 10 atmospheres, and the main vessel stent is inflated at nominal pressure nominally for 10 to 15 seconds. During the second kissing inflation, a non-compliant balloon is applied to the bifurcation core and inflated simultaneously with the side branch balloon to optimize stent apposition, after which side branch balloon is removed. Finally, a non-balloon based method of active side branch protection is the gel microcatheter technique, such as a gel Corsair, in which a microcatheter is positioned in a side branch using main vessel stenting. This creates a physical buffer at the side branch ostium, maintaining access and limiting plaque shift, while having the added advantage of facilitating guide wire exchange if needed. Now, some points about side branch rewiring. Okay, apologies. I got a call from the ED. So I want to talk to you about the rewiring technique. Earlier, I showed you the two-wire and three-wire technique for rewiring the side branch. The standard approach for rewiring the side branch involves using three wires, one in the main vessel through the lumen of the freshly deployed stent, a second in the side branch jail behind the stent, and a third wire advancing through a distal stent strut before the carina into the side branch. However, it is possible to perform this procedure without the third wire, withdrawing the main vessel wire and using it to rewire the side branch, leaving the gelled side branch wire in place to maintain a landmark of the side branch ostium. There's variation in operator preference between these techniques. The advantage of the two-wire technique is that it ensures that the rewiring is confirmed to be within the true lumen of the proximal segment of the main vessel stent, unlike the introduction of a third wire, which may inadvertently engage behind a stent strut. This approach, however, requires careful and controlled withdrawal of the main vessel wire to ensure that it does not move proximally beyond the side branch ostium, which would compromise the integrity of the technique. In contrast, the advantage of the three-wire technique is that it is more reliable and does not risk the situation where the distal main vessel and side branch are both without a wire. In both cases, the jailed side branch wire is only removed after wire access is regained in the side branch. Several strategies should be employed to increase the success of maintaining and regaining side branch access. Before jailing the side branch wire, partially withdraw the wire, positioning the radio-opaque segment closer to the carina, which provides a better landmark of the side branch takeoff and reduces the amount of wire that needs to be pulled after jailing it, potentially reducing wire fracture. At the same time, avoid excessive withdrawal of the wire as jailing across the radio-opaque portion of the guide wire can lead to guide wire fracture. After the main vessel stent is deployed, before attempting rewiring, it's important to perform adequate proximal optimization. Inadequate proximal optimization leaves a crevice in between the proximal stent struts and the proximal main vessel wall into which a wire may inadvertently enter during rewiring. And that's what we're illustrating over here. There are two acceptable approaches for increasing the likelihood of successful crossing through a distal strut: the knuckling technique and the helicopter spinning technique. In the knuckle technique, allow the tip of the wire to form a knuckle as you advance into the main vessel, like this. The knuckle tip avoids inadvertently pushing the wire tip behind a stent strut. Advance the knuckle wire tip past the carina into the distal main vessel, then pull back before the carina until the tip drops in a side branch, then advance into the into the stent strut. In the helicopter spinning technique, constantly apply rotational force on the wire, alternating clockwise and counterclockwise, such that the tip of the wire is perpetually dancing. The dancing tip avoids inadvertently pushing the wire behind a stent strut. When the wire tip is almost at the level of the carina, switch from spinning to linearly directing the tip towards the side branch, then advance the wire through the stent strut. In both cases, the likelihood of successful rewiring can be facilitated by applying a sharp double bend on the wire tip, with the horizontal length matching the diameter of the main vessel. To confirm that the wire has recrossed through a distal stent strut, OCT can be employed for visualization. Failing to spin or knuckle will increase the risk that the wire tip may traverse behind a stent strut, which increases the risk of subsequent inability to cross with a balloon. If a balloon cannot be crossed into the side branch, then even after downsizing to a 1O balloon, that suggests that the guide wire may have inadvertently passed behind the struts of a stent. In this situation, keep the balloon positioned at the point of inability to advance and withdraw the wire to that point, effectively withdrawing the wire from behind the stent struts. Then re-advance the wire with a spinning tip or helicopter spinning tip. Then recross the side branch with subsequent ability to deliver and inflate the balloon in the side branch. Now that we've gone over these techniques, I want just to mention that there are bifurcation dedicated stents, bioresorbable scaffolds, and drug-coated balloons. Um, there are some drawbacks as well as promises to these techniques. They're still in the process of development and testing. If you're interested, you can read papers on this, which I'll show you. But for the sake of time, I'm going to skip over this section. Okay. So let's conclude here and wrap up. In conclusion, bifurcation PCI strategy should be anatomy driven rather than technique driven. Follow that algorithm that I showed you at the start of this lecture. No single method is universally optimal. TAP offers simplicity and avoids side branch rewiring, but may create a more proximal neocarina, especially in acute takeoff angles. Crush techniques provide the best protection against side branch loss when both distal branches are critically diseased, but require systematic pot and kissing inflations. Culotte provides excellent carina coverage but can leave extra metal proximally. Avoid that when there is a large vessel mismatch more than 1.5 millimeters. V-stenting preserves continuous access to both branches but is relatively unrefined and creates a neocarina, best reserved for select cases. High quality pot, precise rewiring, and final kissing balloon inflation remain the most impactful maneuvers for achieving optimal bifurcation results, regardless of the two-stent technique used. The goal of bifurcation PCI is durable vessel remodeling with preserved flow, minimal metal burden, and future access for additional interventions. If you're interested, I invite you to read our paper. This is a two-part companion review, Coronary Bifurcation PCI, Part 1, Fundamentals, and Part 2, Advanced Considerations, which you can go through this DOI, which I'll provide this link here in the Journal of Cardiovascular Development and Disease, which contains all of these illustrations in case you want to look at them further. I also invite you to take a look at these lectures by my co-author and colleague, Dr. Elias Hanna. These are excellent lectures with lots of real-world examples on his YouTube channel. Thank you for your time. I hope that this was a good overview of bifurcation PCI, and with this lecture, you should develop an understanding of the step-by-step of each technique as well as some advanced considerations. And most of all, I think that having a visual understanding of each step-by-step will allow you to better understand and perform the procedure according to best practices. So I hope we have accomplished that here with these original illustrations, thanks to the great efforts of my mentee, Sarah Paulinen at University of Toronto. Thank you very much for your time and attention.